Good morning, everybody. Thank you very much for being here, and thanks to all of those who are connecting from far away online. We know that there have been more than 500 or 600 registrants, and we hope we can provide some entertaining hours ahead of us. So, first of all, I want to thank all the speakers and the panelists that have accepted to come and join us today. They will enrich this program, and I think you will hear from them their perspective. But what we want to do is to really engage each and every of you, both here and also from online, in terms of coming up with some ideas, pragmatic ideas, suggestions about how we approach a problem that, as you will see, is really literally one of the most important we have in medicine today. Just 2 words to explain what this event is meant to be, and the fact that it's not just an isolated thing. It's part actually of a program that we have at King's College London, and this program includes events like this, workshops for information, raising awareness of stigma, but also we have an educational program that it's meant to generate some new tools, including a video and animation that we have just completed, and we will present to you later today with the help of cognitive media partners. So, and also we will develop some leaflets, brochures that we will distribute, including, and the video as well, will be distributed to anybody who wants to use it to educate other colleagues and others in general about the problem of stigma. Use some of this material also for research, and we will particularly try to understand what type of educational approach will be most successful in tackling the problem. For instance, with this video that we generated, we intentionally built it as a whole, but with components that are meant to specifically address one or another problem. One part of it, for instance, is trying to evoke empathy towards people with obesity by explaining the prevalence of stigma and also the impact on individuals. And then the other part of the video will explain the biology of weight regulation with the assumption that explaining biology can also help mitigate weight bias and stigma. So you'll see this projected later. I want to also put this event in context because this is also a follow-up to other initiatives that we have worked at in the past. I want to, so this follows the New York City International Consensus Conference on Stigma of Obesity in 2019, which resulted in a publication in 2020, in March 2020, with a report from this consensus conference and a pledge that came from the experts involved in this initiative. And as I said, this is a program that now follows up on the call and the many calls made by that consensus conference. I want to also take the opportunity to recognize that people and organizations that have helped us organizing this event, particularly in the whole program. First and foremost, Stephanie Ray, you just saw her. She gave an introduction about the logistics here, and she has been really instrumental to put everything together for this meeting and other things. But I also want to say that this event is, and the program and the research that we will conduct as part of this has been funded through a grant that we initiated as investigators, but we actually applied for a grant and succeeded in obtaining this grant from Ethicon and Medtronic. And with this grant, we are supporting the activities within this program. Importantly, obviously, as this serves also as a disclosure, but there's been no input by our funders in the content of this meeting, the selection of the speakers, and anything we've done also with the educational materials. So this is the report that we published in 2020 from the consensus conference. It's a joint international consensus statement involving more than 50 obesity experts. Importantly, at the time of publication, the statement all the content and also the pledge that was associated with it was endorsed by over 100 organizations, which is a record number for medical statements, consensus statements. The pledge included in that say that we all should pledge, and we did pledge as members of that event, but also more broadly with all the endorsing societies and all the other individual pledgers that signed that pledge. We say by that pledge that we want to treat individuals with overweight or obesity with dignity and respect, and that should go without saying. This is just something that is supposed to happen for any individual, for any human being, but as you will see, it doesn't happen for many people with obesity, so we have to restate what's supposed to be the obvious, unfortunately. We want to refrain from using stereotypical images and languages. We want to encourage educational initiatives, including this one, and others similar, aimed at eradicating weight bias through dissemination of current knowledge of body weight regulation. And this was an important point because we believe that misunderstanding of weight regulation is a component, is actually an important factor in causing stigma. We want to also prevent discrimination in the workplace and in education and the healthcare setting and everywhere it happens. The endorsers and the pledgers that have joined in this represents a very broad range of stakeholders, from medical organizations all the way to medical journals and some parliamentary groups, and even many single individuals. If you haven't done it yet, please take a look at the pledge, www.pledge2endobesitystigma.org. It's hosted on King's College London's website, and if you can sign this pledge, we would appreciate it. It's a way to publicly state your commitment to do something about this important problem. Just a reminder, as we will discuss more and more about this topic, about a couple of key definitions so that we can all be on the same page. When we talk about this problem, we refer to a number of things. We refer to weight bias, and this normally means the set of assumptions and also judgments that we pass on individuals with weight and obesity. Of course, negative with a negative connotation. There is a bias in society that's very widespread. Stigma is actually the devaluation and denigration of people because of their weight. And weight discrimination is the ultimate consequence of stigma and bias, is an unfair treatment, if you wish, that happens in different domains, including employment and education and healthcare. Why are we talking about this problem, why we think it's important? I will venture to say that this is the single most important problem we have in not just in obesity, but in all of medicine today. Without addressing this problem, we will not make any progress, not only in the care of people who suffer from obesity, but also in research, in public health initiatives, etc. Everything is misled by bias, and bias is so pervasive that really it's important to understand the gravity of this problem if you want to take forward and make advancements. We know that there'll be many breakthroughs I'll go backward for a second, many breakthroughs in medicine, medical research. I would say that we haven't had a breakthrough in obesity, despite the advances in treatments that we have, refinement of surgical procedures, novel medications, and a number of other things. Realistically, we don't have a breakthrough yet. Obesity has been epidemic for 40 years and more, and counting. And unlike other things that we have seen growing at epidemic rates, the medical community hasn't been able to find a cause nor the cure of this problem. If you look at COVID, for instance, in less than 3-4 years, we found where it was coming from. We identified the virus. We had effective vaccines and public health interventions, so on and so forth. But with obesity, we're not getting anywhere. So I would suggest that the bias, it is actually impeding progress in many ways. So this bias starts very early and affects everybody, and it really takes a serious toll, if I can use the words of a New York Times story. So the consensus conference there that I mentioned before reviewed all the evidence about the problem. And what we found was that there is plenty of evidence that weight-based stigma including internalized weight bias, which is the bias that people who suffer from obesity internalize and themselves not only experience, but become also perpetrators of this as well, can be particularly harmful to mental health. It does increase risk of depressive symptoms. There's evidence that it increases, obviously, anxiety, but also promoting self-esteem, lower self-esteem, but also causing physical stress with increasing cortisol levels, etc., and other issues that are physically harmful for patients who are subject, people who are subject to this bias. So it's not an innocent form of judgment. This is a judgment that carries a heavy toll for people who experience it. And so in the first place, this is a big problem. Many actually use weight bias and some level of stereotyping language and sometimes overt stigma with what's supposed to be a good intent. They think it could be a form of tough love that you can use to encourage people to take care of themselves. But the evidence shows that this is not actually what happens. When people are subject to weight stigma, we're not actually helping them losing weight. The opposite is true. They will actually increase weight most of the time as a result of experiencing this stigma. So there is no benefit in using stigma, and there's all sort of negative consequences. One of them is the negative impact on access to care. This has been discussed at length during the consensus conference, and the conclusions were that there's plenty of evidence that access to care is severely impacted by weight bias and stigma. For one, patients themselves, people with obesity themselves, they don't come forward. They are unlikely to seek medical care for fear of being judged. This is something that for us healthcare providers is very disturbing. If we think that our patients will not come forward because they're afraid of us judging them, I think it really puts us in a serious situation where we should consider if we are effectively accomplishing the mission of a healthcare clinician or healthcare provider. We should not have this kind of situations. But they also technically don't receive appropriate treatment for all sort of reasons, including, among other things, the fact that many treatments of obesity, no matter how evidence-based, are extremely difficult for people to access. For instance, metabolic surgery, bariatric surgery is extremely difficult for people to access. It's been difficult for many, many years, including not for reasons linked to lack of or inadequate insurance coverage. And this consensus statement made it very clear that policies that undermine access to evidence-based treatments of obesity are indefensible and ethically objectionable. I want to use this case of bariatric surgery, bariatric or metabolic surgery, not just because I am a surgeon, and obviously I know a little bit of it, but also because it is very revealing about the consequences of stigma on access to treatment. We know very well that there is plenty of evidence from decades long, evidence that weight loss is sustainable after bariatric surgery. So there's 25–30% weight loss at 20 or 30 years from surgery. It's extraordinarily effective. Not only is effective on controlling body weight, but surgery is effective at improving or even resolving most of the obesity-related conditions, most notably diabetes, which in some patients we can venture to say it's almost surely cured, at least in some of them. We have patients with documented 10 years complete remission, no signs of diabetes, even if they were on insulin and had severe diabetes prior to surgery and have no sign of diabetes for over 10 years and beyond. I mean, we don't know what a cure of diabetes looks like, but this seems to be quite a potential example of it. Surgery reduces mortality from obesity, and especially from obesity plus diabetes. And every study that's looked at mortality has shown this. So it's a life-saving intervention, and surgery is also a cost-saving intervention because, of course, many patients use medications and they don't need it anymore. The prevention of complications also reduces the burden on healthcare services and so on and so forth. So if you put all this together, what not to like of it? you would say that if there were a surgical intervention like this that could treat Crohn's disease, ulcerative colitis, or any other form of disease, everybody should get it. Well, if you look at the numbers, less than 1%, consistently less than 1% of people who meet the criteria, we're not talking about people who have obesity or people who have diabetes, people who meet criteria for surgery, which are already a selected fewer, less than 1% get access to this treatment. Now, imagine if you had coronary artery bypass that is only accessible to 1% and not accessible to 99.8% or 99.2% of people who meet criteria for coronary artery bypass. You would say we have a problem. And we've been dealing with this problem for so long. We will speak later about health bias in healthcare, which is a very important problem, and how doctors are not immune, unfortunately, to this form of bias. When Hippocrates described our job description as clinicians, he said that we should cure sometimes, treat as often as we can, but fundamentally, we should comfort every person who we see, because at the end of the day, that's what it's supposed to be our job. And I would say that there is plenty of evidence that we are not successful in this job, in this mission. In fact, the opposite is true. Just as an example of this, yesterday in my clinic, one patient came and she was crying in front of us. When we asked why, she told us she was very distressed because when she comes to hospital, she always feels so distressed. And she cried and she said that she had a sleeve gastrectomy 2.5 years ago. She lost 30% of her body weight, 48 kilograms, extremely successful, even though her BMI is still in the range of obesity. So that was a success, but she was feeling it and living it as a failure because a consultant of another specialty that treats her for epilepsy told her that her epilepsy was due to her obesity. And that even when she lost 50 kilograms, she still was in BMI with obesity, and therefore her epilepsy was not improving, indeed, despite she discontinued all medications for diabetes, etc. When she had a CT scan because she had a crisis and she ended up in the ICU, the nurse who was helping her, coming out of the table of the CT scan, told her, wow, I thought you were fatter than this. Which I assume was supposed to be a compliment. But imagine if we, and I think it's safe to say that nurses and doctors are nowadays quite professional in their jobs, and they would never make comments on physical appearance of other patients for any other form of physical appearance or any other problem. Why do they feel it's okay to say something like that? Why would we do that with impunity? Now, surgeons have treated the obesity for so long. You would say surgeons know better. That's not true. This is the International Federation for the Surgery of Obesity at World Congress in 2016 in Rio de Janeiro. I was in the back of the room, and they were asking a room with about 2,000 people in, with surgeons and other allied healthcare professionals that work in bariatric surgery. If a patient regains weight after surgery, what is the most likely reason? And there was a number of options. The operation wasn't done well. Of course, surgeons would never admit to that. Or there's a problem with the biology of the disease, and et cetera, et cetera. Well, the answer was instead, overwhelmingly, that the patient is the primary responsible for obesity recidivism. And if you really look at that, I took that picture from my phone, so it's a bit blurry, but 80% of surgeons who do these operations for making people lose weight, they say, oh, it's the patient's fault if they don't achieve what they're supposed to achieve. And when some of us, including myself, raise the hand and say, well, if this is what we believe, we should close the shop. We should not do this anymore. Then we re-voted, and we had still a resilient 60% on the second vote, you can see in red. So it's really a resilient thought among a lot of professionals. But what causes such a resilient bias and stigma of obesity? We tried to understand that with the consensus conference, and the conclusion was that the idea of obesity, the causes of weight bias, depend on the idea that obesity derives from individual faults, and especially laziness or gluttony, and that this idea is what provides the foundation for weight stigma. We also did some research at King's with my colleagues and also with collaboration by Stuart Flint, where we did some research surveys among 4,000 people in different countries. And what we found was that when we looked at stigma of obesity measured by matrix of weight biases, it's a proxy of weight stigma, and how some people responded to certain questions. When they were asked if obesity can be cured by committing to a healthy lifestyle, what we found was that, in fact, those that do have that belief are more likely to have higher scores of weight bias and stigma. And also, those who think that the most effective treatment is a diet and exercise for even severe obesity tend to have more higher scores in terms of weight bias and stigma. Why this is important? Because if you really look at the population, then we did a survey this past summer in America on 1,000 people with obesity. The vast majority still believe that you can actually cure obesity with diet and exercise, and actually they think that the most effective treatment for obesity is diet and exercise. So if we know that this actually contributes to bias, we also know that it's not entirely true, it's actually not true, then obviously we see that here there may be a problem that could be a target for us to address if we want to tackle the problem indeed. So what I would say that this example shows is that with the causes of weight bias and the fact that it's so resilient, unlike other forms of bias and unlike other bias towards other forms of lifestyle-related diseases, like cancer is lifestyle-related, but nobody would tell somebody with lung cancer, stop smoking and the cancer gets better, right? But we still do it for obesity. So the problem here is that we think people with obesity are guilty because they get obesity by whatever lifestyle choices. But they're also guilty twice, because allegedly they will not be doing enough to undo it, as if you can undo it. So that's probably more the unique point that we have in this form of in weight bias that we don't have with other things. It's this idea that you can go in and out of it, back and forth, at will, as you want, whereas evidence shows us otherwise. So why this is it? This is because we have a clear understanding, innate understanding of how we regulate body weight. We think it's just as simple as we eat too much, we exercise too little. And to some extent, that's true. We all experience that. The problem is that this is true only within a narrow range. The causes of obesity are believed to be, even in medical textbooks, are believed to be too much food, too little exercise. However, is it really volitional, the regulation of body weight? And what we know is that the biology tells us a different story. You know, the main centers involved in body weight regulation are in the hypothalamus, which has nothing to do with the cortex or other places of the brain that really are important for volitional choices. There's also plenty of more other mechanisms from the gut and other organs that are involved, and we have no control over those. So there is not a biological rationale to say that appetite control, food intake control is volitional. The same applies to energy expenditure. There are studies showing that energy expenditure total daily energy expenditure is substantially similar in people who live in London or New York and people who actually live in the South African regions, where they have to walk every day or run every day to get their food and so on and so forth. So this is not surprising, because we know that energy expenditure is regulated in a way that compensates for any change in body weight. So if you lose weight, your energy expenditure decreases, and vice versa. So it actually contrasts your attempts to lose weight. So there's a biology there that tells us that in fact it's difficult to lose weight. I'm not saying that exercise is not important. Exercise is fundamentally important because you need to, because it can improve fitness and cardiometabolic risk and everything. But when we talk about weight regulation, exercise, there is no evidence that exercise can actually make people lose substantial weight for long term. That is contrary to what we normally believe. So finally, I want to say that energy in, energy out is biological. Both of those things are biological regulated, and not different than other things like temperature, oxygen in your blood, and hemoglobin, etc. Those things are vital functions that, not surprisingly, have a strong biological regulation behind. So your body really wants to make sure that you can't just decide to commit suicide by altering some of these vital functions. And so it will control it and prevent you from just deciding to change at will. Now, obviously, you can do it to some extent, but not for everything. I want to stop there because I think for an introduction, this is probably more than enough. And I will not take questions, not because I don't want, but because the questions will be allowed for all the other speakers and also for the panel. This was supposed to give you a sort of flavor of what is about to come with the next speakers. Thank you very much for your attention.